out from the test at that point. So we'll cover a couple of different things. Just quick version check because I updated it last night. Slide number 4 should have an agenda on that, and I'll keep that rolling agenda just so we can keep track of where we are in the lesson. Just make sure you got that one. I'm going to pull up the bonus material. It has a couple of questions. It's uploaded on Canvas if you want to drag that whenever you want to. It has a couple of new, let me slideshow, pull it up for you guys while you're probably frantically looking for that in the background. It should be lesson 6 recap under the main neurology page 2. Okay, so quick recap from last time. We covered syncope, figuring out it fits in one of 3 categories, which I like this chart just to say, hey, reflex or vagovasal, I got my orthostatic and I've got my cardiac. Look at the things that make them different. These ones are pretty straightforward to write the test questions. And oops, too far forward. We also covered some vertigo, and that big split was peripheral versus central. And I pulled that peripheral versus central. What are my things that I look for that says, hey, this is more of a central cause versus this is more of a peripheral cause? Which one do I want to have? Which one's worse? Between a central versus a peripheral cause of vertigo, which one's worse to have? Central. That kind of leads us into a lot of different strokes, head trauma, tumors, bad things. Peripheral, some more, vestibular things that we have treatments for that are a little easier to deal with. What if I have someone that has a vertical component to their nystagmus? When they look, their eyeball's kind of twitching up and down. Can I start thinking, hey, this might be one of my peripheral causes of vertigo? Vertical nystagmus up and down? Central. So if I have that unidirectional, it doesn't switch, and it tends to be horizontal in nature, that's pretty reassuring. Those are kind of the big ticket items, but pay attention to this chart as you're doing your studies. That'll keep you straight. I pulled out everything from the slides that I could on those. And then we covered some seizures. I know that was kind of a hard topic because we were a little, sorry, go ahead.
Sir, can you hear us?
God, is that you? Yes, I hear you. Are we working audio video still?
Yeah, there's like a major delay between your voice, but we also can't hear you.
Can I do the dual influencer hands? I'm gonna get really tired doing this for 2 hours. Oh God. I wish you didn't. Hold on. I'm sorry. I'm joking. I'll do my best with what I got. All right. So with. Jeez. Can I put them back down?
I think we lost you again.
All right, hold on. Alternatively, we can use the microphone that goes.
If you're talking right now, we can't hear you.
Hello.
There you are.
Hi. Paige, can you get me or no?
I can hear up now. If it doesn't work, we'll switch back.
Okay, we'll give it a try. Let me know if I start clipping out again. I'll use my my big major voice. All right, so we covered seizures. We talked about the clinical approach. We talked about focal seizures and generalized seizures. Something that I created new for you guys was these two kind of like separation charts where it's just like, hey, what are the things that differentiate them compared to other things? Keep this in your studies moving forward. Sorry I didn't have this available to you guys yesterday. This is new. But I have one that's on my focal seizures. Focal seizures, are we losing consciousness from that typically? Or is that more of my generalized seizures with both hemispheres are affected?
Sir, we still can't hear you over there.
Okay. Can we switch up the microphones to the one that goes overhead between both?
Yeah.
I'm sorry, that's loud as I can talk and maintain it.
If you could still wear it.
I'll wear everything, sure. Stand by. Can we grab the mic from the other side?
Yeah, they're bringing it over.
Okay.
They should be.
Yeah, that'll work good.
No, I have another thing. It might be a network, but it's my guess is it's that. That was just a stall. Not fucking dead. Yeah,
You said it was like somebody behind us.
It could have been. I'll tell him from this. Don't make it good.
I don't think it's anything like text. I was just trying to do it to make things. If they can't figure it out or can't fix that,
I'm going to do a quick mic check. I think the juniors can hear me. For real? It's like super loud for me.
yeah, the drop off super bad.
It drops off out back because it's going forward. Okay. What about the sophomores? Are you guys able to hear me over there?
You got thumbs up.
I got thumbs up. We're good. This is a good volume for most people. Jesus.
All you.
All right. Are we good with this level of volume for you guys? Cool. Good over on sophomores. Fantastic. I'm going to start real quick from the beginning just because that was kind of broken up. We got plenty of time. This lesson's shorter than the other one, so don't sweat. So we're going to do a quick recap of lesson 6. We covered syncope, we covered vertigo, and we covered seizures. Big thing with syncope, we have 3 general classes of that. We got the reflex and the vagovasal that you guys are probably familiar with. That's typically some sort of trigger that we see with that. Do we expect to see a post-ictal state, meaning people are kind of confused for about 30 minutes after having a vagovasal event? No, that's not a very typical thing. It should only be a couple of seconds of confusion. That's going to be a differentiator that's going to, 1, help you out in clinic, but 2, help you out on test questions. If someone's consistently confused 30 minutes after, do not call it a vagovasal. We think of orthostatics. Can anyone tell me, and I want to see a raise of a hand real quick if we can anyone tell me what key thing I'm looking for in orthostatic that says, oh yeah, that's orthostatic all day? One person raise a hand and give me a... Don't worry, I got you guys. So what happens with orthostatic, I'm looking for a level change. That's going up from sitting to standing. That's going to be the one thing that's going to clue me into orthostatic. And then cardiac, I got 2 things that kind of clue me into cardiac just for the people playing at home. And I'll tell you guys because I know it's hard to raise a hand, especially in the dual classroom thing. Don't worry. Plus, they can't hear you anyway. I perfectly understand. So with cardiac, the 2 big things, if it's fainting while exercising, no prodrome, that's super scary. What if I'm laying down in bed and all of a sudden I pass out? Bad. We think cardiac. So either supine or exercise, start to think cardiac. But that's a good way to differentiate those. A ton of other details in there, but those are the high testable ones. All right, next thing we covered vertigo, both the peripheral and central. I think for the sake of the sophomores, we'd much rather have a peripheral than have a central. Central's scary things. Peripheral things that we can actually deal with. I have a couple of test questions on those to kind of show you the way I like to differentiate those and build those test questions. You guys got this during ENT, so I'm not going to go super heavy into it. There's no new details. It's a lot of stuff that's familiar, but I'll show you the kind of clinical details I like to focus on so you understand the questions I'll ask. And then seizures. This one I had a little bit of hard time teaching with because I didn't have that comparison chart for you guys yet. So in that bonus lecture material, I got the focal seizure types. Focal seizure types. Am I losing consciousness? No, that's going to be my generalized seizure. Focal only affects one hemisphere. So I might be aware of it, meaning focal aware, or I might be unaware of my actual deficits. That means all of a sudden I start kind of talking mush mouth, or maybe I'm very emotionally labile, some odd behaviors, but I'm not really aware. Other people do see it happen. Let me pull up my laser pointer so I can show you guys where I'm talking. Okay, so focal aware motor, something starts twitching, and we had kind of two very specific flavors of that. These ones are high testable items. Jacksonian march, it kind of starts in a finger, works up to a wrist, works up to an elbow, the whole arm starts raving. And then Todd paralysis, that's that localized postictal paralysis. So I finish raving, and then my arm stops working for a long period afterwards, and it just doesn't move for about 30 minutes before it starts happening again. And then my non-motor symptoms, that could be sensory things, that could be cognitive stuff like deja vu, having a very weird feeling that things have just happened in aura. It could be autonomic, so that kind of nausea, flushing, pallor. And it could be emotional. All of a sudden, we're very emotionally labile and we don't know why. And then we got the impaired awareness, and that could be either motor or non-motor, but we're just not aware that it's actually happening to us. And then this last category here, that's that one that starts off as focal and it spreads to both hemispheres. Once I affect both hemispheres and I have abnormal electrical activity throughout my brain, am I still able to maintain consciousness? No, because things are Thank you. I really appreciate you for that. That feels great. All right. And then I got generalized seizure types. These are my ones that start to affect our consciousness. Absence seizures. Think your young 8-year-old that's in school and they just space out, but hundreds of times a day. Their grades start dipping off, and finally, I feel like you're trying to do one right now. That was actually really good. So they just kind of space out and stare, and it gets misdiagnosed as ADHD sometimes. It's very hard to recognize this, but think, hey, younger patient, difficulty in school, dozes off, and just kind of, they don't lose postural control. These kids aren't falling over like a drop attack like I tried to demonstrate yesterday. Generalized tonic-clonic, this is what you guys typically know as seizures and have seen, where it's like very dramatic. We got that tonic phase, meaning, hey, we lay down, we don't move for a second, may or may not stop breathing. And then after about 20 seconds, I'm going to start having a lot of vigorous muscle movements that last about a minute. What happens when it lasts longer than 5 minutes? Status epilepticus, and we start reaching for some different medications. I have a test question. Atonic, that could be your drop attacks. It's very quickly, we just lose postural tone. Brief 1 to 2 seconds. We don't typically have a postictal phase for these ones. And then my myoclonic, that's all of a sudden my arm just kind of flings out. That can be normal in some people at night when your leg just kind of twitches. Other people, it becomes very problematic to the point where they're trying to brush their teeth and all of a sudden the toothbrush is flying across the room. All right, so quick check on learning, a couple of questions. Don't worry if these don't come easy to us yet. I really want to show you my test-taking strategy and the way I differentiate things, because then when you take my test, because it's only a 2-blocker, you're not super surprised. You understand the depth I'm trying to go into. It's my way of gauging what you guys are able to understand, especially for the sophomores. I'm trying to write to a sophomore level. But I know this has drugs. I know we're going through pharm, and you're like, oh, please, no drugs. I'm going to show you a secret, because I'm going to test on drugs without it being a drug question. I got an 18-year-old male brought to the emergency department, continuized generalized tonic-clonic seizure after about 5 minutes. Airway supported, supplemental O2's on board, intravenous access is going, and bedside glucose is normal. Which of the following medications should be administered first? And some of the things that I pay attention to as you move into junior and sophomore semesters, you're going to get answers that have really good, like, hey, all of these are like anti-seizure or benzos. Those are all really good options. Which one's the one that I want to reach to first is going to be a big differentiator. So when you see like which should be administered first, know something is different. So what do we see about these test options? I know this is an anti-seizure med. I know this is an anti-seizure med. This one's anti-seizure. This one's anti-seizure. I didn't hammer it home like, hey, I like this one over that one. I like Keppra. I like levetiracetam. I like triliptal. You're just going to see those in clinical practice, but those aren't necessarily the best ones. What's the one that's different? Lorazepam, because I can get diazepam on board and then actually stop that seizure rather than trying to prevent the recurrent one. So just pay attention to that. I'm not going to ask dosages or routes or give you really confusing things. It's really meant to be like, hey, here's a drug question without being a drug question, because you guys are getting it in pharm enough as is. I will ask questions about drugs just for clarity's sake, not to throw you guys off. All right, I got 3 questions. They're all very similar, just to kind of highlight some of the differences here. They're all on those peripheral vertigos that we have. So I got a 26-year-old woman presents with intermittent vertigo episodes lasting about seconds. typically associated with head movements, does not have a history of migraine headache and or no hearing symptoms. What's the most likely diagnosis? Do most people feel pretty good about this one? This is a pretty straightforward benign positional vertigo. Anytime you get that brief seconds, head movements, I'm kind of cluing you in. Why do I have to mention her migraine history? Because I got that vestibular migraine, and you could make a pretty darn good case as a student to say, well, why don't they have vestibular migraine? That lasts a very broad range of times. So I have to give you enough details that you can differentiate out the different ones. So when you get these scenarios, pay attention to what's there and what's not there, because I'm trying to make it so it's like exclusive. It's not, it could be two of those. So kind of play on words. Now I got the same 26-year-old woman, but she has persistent vertigo, lasting for about 3 days with associated hearing loss. Does have a recent history of a resolved viral URI. The patient does not have a history of migraines again. What's the most likely diagnosis now? Vestibular neuritis? What about labyrinthitis? I feel good it's not vestibular migraine. I gave that one away. And we know it's not this one now because it's not, BPPV doesn't cause that consistent one. And the perilimb fistula, what am I looking for that one? When does that one become an option? Some type of trauma to the ear, slap fight, you name it. Too much Carl Gustav. All right, so I got vestibular neuritis versus labyrinthitis. Which one do I like? Which one has hearing loss associated? Did I do that right, or did I do that backwards? I gotta double check that one here. I might have put the wrong answer. All right, so vestibular neuritis, not typically associated with hearing loss. It should be labyrinth. Sorry, I highlighted the wrong one for you guys. Make sure you correct that. So labyrinthitis, I think more of it's actually involved, so we're going to start to see those hearing loss issues. To be clear, labyrinthitis because we have hearing loss associated with it. All right, last version of this. I got a 26-year-old woman presents with persistent vertigo over the last 3 hours with nausea and photophobia. Patient does have a history of migraine headaches, but does not currently have a headache. What is the most likely diagnosis? I'm hearing some snakes saying C in the background. They're all, yeah, it's snake jazz. All right, so am I thinking labyrinthitis or vestibular neuritis at this point? Doesn't really mention much about hearing loss, but I have other options that are more attractive. I like vestibular migraine, but they're not having a headache right now. Do I have to have a headache in order to have vestibular neuritis symptoms? Or excuse me, vestibular migraine? No. You could have a history of migraines, and that kind of clues you into it clinically. I don't have to actively be having it because I say, hey, they have nausea and photophobia. They're having migraine-like symptoms along with this, but you don't have to have that generalized headache in order to be a vestibular migraine. Boop. And that does it for the review. I'll pull up the main slide deck now, and we'll get through altered mental status together. All right, we should be on this one. Just for version check for you guys, make sure on slide number 4, I think on your decks, you got an agenda that kind of looks like this. So things that we want to cover today is altered mental status. Sorry, I'm all over the place. All right, altered mental status and confusion. That's going to be delirium, and that's going to be dementia. And then a lot of these other things are going to fit within that kind of framework. So our agenda for today, we're going to talk about our general clinical approach to someone coming in with kind of an altered mental status. We'll talk about delirium, which is kind of the more acute phase. And we'll talk about dementia. And we'll talk about initially how to separate out the two, because it's very important to separate out your delirious patient from your demented patient versus your delirious demented patient. You can have people present with both. Much like we consider peripheral versus central causes, we're going to pay attention to those things that kind of clue me in. Hey, is this more of a central issue or more of a peripheral issue? All right, so what's the diagnosis? Someone's coming in confused. It could be over a long period of time. It could be over a short period of time. It could be sudden onset. It could be onset over a couple of days. It could be years of onset. We got to pay attention to those things because that helps us determine, hey, is this person delirious because of a reversible cause, or is this person having generalized decline of actual cognitive ability over a long period of time? And we have a couple of other things that can kind of confuse us. Let me pull up my laser pointer. Psychiatric disease kind of plays a role in this. Intoxication and withdrawal can kind of confuse us a couple of times. And then structural CNS disease kind of falls into that dementia category. So we got to determine, hey, which one of these, delirium, dementia are our big two. Most of the things we're going to talk about today fit into those. So delirium, think, hey, sudden onset. Typically an underlying condition is causing me to have delirium. I'm not delirious primarily. It could be infection, it could be medication toxicity, it could be recent illness or surgeries. Signs or symptoms, they tend to fluctuate. Has anyone ever heard of the term sundowning before? Or had a grandparent or someone that has had those symptoms? Typically they're fine during the day, then all of a sudden their courses will completely reverse at night and they'll show crazy symptoms. And it typically evolves over hours to a week, and it's reversible because a lot of these things we can treat and that will actually resolve the delirium. Dementia is more of this gradual decline. It's actual structure changes in the brain. That's when we're talking about Alzheimer's and a couple of other conditions that we'll put in there. Once we fill that out, it'll make a little more sense. But again, dementia doesn't really have this waxing and waning course. I don't have any of these underlying conditions that are cluing me in, because the biggest thing I don't want to do is label a delirious patient as dementia, because then I'm not treating an underlying condition. So when we're approaching these two in general, the biggest thing we need to do is make sure we're getting a baseline cognitive function test. What are some of our tests that we can do in order to get like a number value out of 30? Like, hey, how good is this person cognitively? AMSIT's kind of the full-on, like, explore everything going on with them, AMSIT or aseptic. But what's more of those like structured objective tests that we can do? MoCA's a really good one. What's the other one that we have? Mini mental status exam, very good. Okay, so baseline cognitive function, get that score. I like MoCA. It's a little bit better at determining that kind of like really mild level of cognitive dysfunction. That tends to be used more in clinical practice recently. Time course, capture that, because that's going to clue you in faster than anything else. Slow progressive decline, I'm thinking a demented patient. Stepwise incremental changes, I'm thinking more delirious. And then acute onset of confusion, definitely fitting into the delirious category. The other biggest thing that we got to look at is our meds. Has anyone ever heard of the beer list before? It'll kind of come up when we actually teach geriatrics, but it's this idea that there's this list of drugs. You can look it up online later if you want. There's a list of drugs that are actually contraindicated in your geriatric people just because they're super common that they cause delirium and dementia in older folks. So we got to take a look. As we get older, we end up on longer and longer lists of meds. We got to go through and we got to look for the things that we can know cause issues. Antihistamines tend to be pretty big. If someone comes in with back pain, we put them on muscle relaxers. It can definitely cause delirium in an elderly gentleman. Benzodiazepines and opioids, obviously. But when you start to think diuretics, hey, this person might be dehydrated, resulting in a lot of issues with that. And then sometimes they're even treated for Parkinson's, and those medications that we put them on that have psychoactive capabilities, those can cause problems too. And we might not want to take them off those medications, but we might have to treat them comorbidly. And don't worry about memorizing, hey, here's the exhaustive list. Just have a kind of general idea. I'll clue you in later about, hey, which ones I want to pay attention to. Don't memorize, hey, here's all the things that can cause problems. I don't see every single patient like that. But I have a pretty good idea before I put an elderly folk on a muscle relaxer. I'm like, hey, I want to make sure this doesn't make this person become delirious. Other things that I want to look for in the history, and don't worry about memorizing this list for a test. But I'm looking for cardiovascular disease because if I throw clots, that can cause dementia over a period of time. I can have infarcts that cause my brain to not work anymore, very incrementally rather than large-scale stroke. Diabetes mellitus, because that's a prolonged inflammatory state, really increases our cardiovascular risk factor. I'm worried about throwing a clot in the brain as well. What about renal and liver disease? Uremia can be a big issue because now our metabolites are like way out of balance compared to what we want to be. Sleep issues and prior dementia. If someone's been demented before, they probably have some baseline dementia that you have to take into consideration because they may become delirious on top of that. If grandpa's not sleeping, that can cause a lot of issues. Seizures can kind of become an issue with these ones. Head trauma, especially as we become older, we fall down a lot and we end up hitting our head, but it really doesn't get diagnosed like, a younger person getting into a football accident. Pay attention to head trauma in elderly folks. And then alcoholism and drug use becomes really prevalent in psychiatric history. There's such a thing as pseudodementia where, hey, turns out grandpa was actually just depressed and that caused a lot of symptoms that looked like dementia. We'll go over that at length. All right, you get someone comes in with that altered mental status, not like completely passed out, but waxing, waning course of cognition. Initial priorities, get your ABCs. It's the same thing as everything else. Make sure they're stable, get your vital signs, and check that point of care glucose very early on. Hypoglycemia is one of the easiest ways to get yourself out of a full-on workup. It'll save you a lot of trouble getting that glucose early. And then get your focused neurologic exam. Do the full-on thing. Make sure we don't have focal neural deficits or other issues going on. Sit there, go through the cranial nerves, do the cerebellar ones, because that might help you localize where an actual infarct might be doing. Because just getting an MRI and an AMS is a risky business, because you may find all sorts of findings in elderly folks, and you're like, I don't know which one's actually causing it. But looks for signs of toxicity, infection, trauma, meningitis, focal neurologic deficits, dehydration, medication patches. Does anyone know what that means? As we get more elderly and we have pain, sometimes we're on opioid pain control, especially in palliative care scenarios. You may have a fentanyl patch on. Grandma might forget to take those off and have 5 of them in a row. Consider removing those. Skin rashes, meningococcal versus DIC. Head and neck stiffness, what am I looking for? Meningeal signs at this point. And then chest and abdomen, again, looking for signs of infection. That was just kind of a stepwise approach through a body. And then your mini mental status exam, like we talked about. Mini mental status or MOCA, either of them are good. Pay attention to this one. This is very testable. Attention testing is critical in delirium. That's one of the first things that goes out when we start having a delirious patient. So for people that are doing the mini mental status exam, it says attention. Expect this 5-point score. Those serial 7s, stopping after 5 answers, that's the first thing that's going to go out in a delirious patient. And then if you're doing the MOCA, they have a separate one where you're like, hey, can you do it forward or backwards, or tap every time you hear the letter A, or serial 7 subtracting for 100. That's the first. They're always going to be able to tell you that's a lion. But once this one goes out, you know things are starting to look more towards a delirious patient. All right. Pay attention, and this is kind of like the short version of a mental status evaluation, but pay attention to their speech and language. You don't have to do the full aseptic right off the gate unless someone tells you to do that or that's what you want to do for your approach. But just pay attention grossly, like, hey, are they able to talk, or am I looking at like a Broca's or Wernicke's aphasia, or am I having issues with some of the like global just talking? We'll talk about a couple of the different versions of aphasia here. Actually, I have it right here. So Broca's and Wernicke's, we tested on that one. You guys did great on that one. There's some more flavors of aphasia. Don't worry about separating. I'm not going to ask more and more questions. Just know there's a couple more. I can have global aphasia where fluency is impaired, everything's kind of wrong, comprehension is impaired. It's like a little bit of everything that might be difficult to separate out from a Broca's. I can have conduction aphasia where fluency is preserved, but comprehension is preserved, but I'm having a lot of difficulty actually getting the words out. Again, that sounds a lot like Broca's aphasia. We didn't go this far into it because those are very difficult to separate out. Transcortical motor, fluency is impaired, repetition is preserved, comprehension is preserved, may have an associated right hemiparesis. It sounds like Broca's. A lot of these are kind of like very small, like, hey, how do I differentiate out those versus others? I'm not going to test you on this. These are just kind of for your background information. There's more flavors of aphasia. Just keep it into Broca's and Wernicke's because those are what you're going to see the most on tests and the easiest ones to differentiate out clinically. Let's talk about memory real quick, just because that's involved in some of the testing we're doing for the mental status exams. I just want to stratify out what our different types of memory are. So I like to think of it in terms of computer parts. If that resonates with you, great. If it doesn't, I apologize, but I'll make sure I spell it out. So I got my working memory. That's about 30 seconds. That's about enough to memorize a phone number before we had area codes. I think of that as like the registers on a CPU. It's that like immediately used memory, like I'm using immediately. It's very vulnerable to distraction. You can say, hey, grandma, over here, and she completely forgets what she was talking about. This is used by our reticular activating center, so things that keep us awake. As we become less awake, it's hard to have a better working memory. Prefrontal cortex and parietal lobe, because it's at that front part of the brain where I'm actively thinking about it. And we test this with repeat after me, and if they can say the words back, we know their working memory is good. Next one I got is this episodic memory. I like to think of it as RAM, where it's kind of like still kind of short-term use. It's actually done in the hippocampus. I think someone said the effect of a hippo walking across campus, you won't forget it, is a very easy way to memorize that your hippocampus is involved in memory. But this one stays in there for a little bit until we actually lay it down over time, and they actually shift into long-term memory. So this is kind of like my in-between is my episodic, think RAM, pretty quick, easy access. This might be used in that 3 to 5 minutes because a lot of those tests have you, hey, repeat after me, and you go do some other things, and then you say, all right, 3 to 5 minutes later, hey, can you repeat those 5 words I had you do? That's episodic memory at that point. And then lastly, I have lasting memory. That's my long term. That's a hard drive right there for People that have never looked inside a computer. That's long-term storage. It takes a long time to get it back out. It's actually stored in the left anterior temporal lobe, which if you want an easy way to memorize that, think, all right, I'm trying to think of something I thought of a long time ago. I'm going to start scratching my left anterior temporal lobe to try to get it out. And also used in our frontal lobe. All right. One of the other things that's used on that mental status exam is executive function. I think we've all kind of talked about this just in like common English. We're like, I'm not having a lot of executive function today. I can't even do what the things I need to do. It's involved in planning, organizing, self-control, metacognition, working memory. If I could like double my executive functioning, I feel like I do really well at IPAP, but it's a limited thing. You can only do so many things throughout the day. When we have executive function being impaired, we see poor impaired planning, poor judgment, apathy, inability to complete multi-step tasks. That strongly localizes to that frontal subcortical networks because, again, it's kind of higher order thinking where I'm talking about executive function. And then paying attention to some of these historical red flags. Again, we're trying to assess an altered mental status patient, trying to fit them into a delirious versus dementia. We covered a couple of things under MOCA and mini mental status exam. My historical red flags, if I have a progressive declining level of consciousness neurologic exam, that should clue me in. If someone's actually kind of passing out and stop talking, that's a red flag. And if I have pupil asymmetry, that's a pretty easy neurologic deficit to pay attention to. Seizures, repeated vomiting, double vision. Again, pay attention to these ones in your delirious versus dementia patient. It's not just grandma's cross-eyed now. No, that should be a red flag for a much sooner workup. Worsening headache, can't recognize people, places, or disorientation. That might clue you in that someone might be more advanced level of Alzheimer's. Behaves unusually or seems confused or irritable, slurred speech, unsteady on feet, weakness or numbness in the legs. All these things are causes for secondary injury. Grandma wanders out into traffic now, or we fall down more often. Pay attention to these red flags, clue you in. It's like, hey, maybe I need to socially admit this person. AKA, I can't release them home to themselves. They don't have their ADLs anymore. They're at risk for hurting themselves. All right, so just kind of a once over. Delirium, I'm thinking the acute ones. I'm thinking responds to at least some types of stimuli appropriately. Can appear sleepy, disoriented, inattentive. Level of consciousness may be impaired by differing levels, any age, and it can occur, it's typically reversible. Younger people don't end up being as demented as much. Younger people can get delirious, especially if they're critically ill. But dementia, typically chronic and worsening over time, usually appears normal. Grandma's just kind of withdrawn compared to normal. Level of consciousness is retained in these people. An impairment with the content of that actual consciousness rather than the consciousness going out. And it typically is more in the elderly, but not always. You can have early onset dementia. And then typically irreversible. We can treat some of the underlying symptoms and give them back some more of their ADLs and try to stop progression, but I'm not going to cure a demented patient. More comparison charts, just kind of less words. Delirium, attention problems. Attention is going to be the first thing that goes out. It's my second time repeating that one. I'll make sure I write a test question for you. And fluctuating levels of consciousness. All right, hours to days, delirium, months to years, dementia. Sorry, I think this is just kind of re-hitting the same ones. One thing that's different here, I'm going to put pictures. Does anyone know who this is? Louis Armstrong plays the trumpet. So if I have fluctuating cognition plus hallucinations, nothing that we've talked about is referenced hallucinations yet. I'm thinking Lewy body dementia, and I have some slides on that independently, but I want to introduce this idea early, that if we have hallucinations, think grandma sees Louis Armstrong in the corner of the exam room playing a trumpet and he won't stop. So as soon as I have a demented or delirious patient and I have hallucinations, think Lewy body, Louis Armstrong. Right, delirium, I think this is just kind of a once over again. Hallmark is waxing, waning levels of consciousness. I'm repeating same things here. All right, so now we're going to go into delirium and we're going to go into the selected causes, the things that are actually fit under that, because delirium's great. We got to identify the cause because then we can reverse some of the cause. Things that are different, attention impairment, got it. Can be hyperactive, hypoactive, or mixed. Not all of these guys are like withdrawn. Some of these people can be very, very irritated and agitated, or going back and forth between the two. Hypoactive delirium is easily missed in a lot of people because you might just assume that, hey, grandma's a little more sleepy today. It's not going to be obvious. When someone's hyperactive, it's pretty obvious that someone's acting erratic. Don't memorize this. There's like 2 different mnemonics. I like this one. The other one is I Watch Death. You can Google search whichever one you want. Just keep it for yourself in clinical practice in the future because you get that, hey, I think this person has delirium. What are the common causes of delirium? This is a really good acronym to keep you straight. It's literally just delirium, so you can't forget it. But the D is for drugs. The E is for epilepsy or electrolyte imbalance. The L is for liver failure or low oxygen states. The I is for infection, especially urinary tract infections. Has anyone in here worked EMS before? And seen grandma with the UTI and you can smell it from across the yard and they're demented or delirious? Yep, classic. All right, and pneumonia and sepsis, I think R for retention of stool and or urine. Elderly folks tend to get constipated a lot, or they may have issues with benign prostate hyperplasia. They may have difficulty actually urinating. When you actually end up with way too much of that, it can definitely cause delirium. Intracranial abnormalities such as seizure, strokes, or trauma, maybe an epidural bleed. And then uremia. Does anyone know what uremia is as like a concept? That's when my uric level is too high because I'm thinking kidney dysfunction in these folks. And then lastly, I can have metabolic problems. That's kind of covered in some of the other ones. But again, checking glucose very early on in these delirious patients. I think for the sake of clinical practice, memorize that I need to look up a acronym. I can Google search it later. I'm not going to ask you what's the R of delirium on a test question. So some of the very common causes, alcohol can cause it in a couple of different ways. And again, we hit ataxia pretty hard last time as a clinical sign. I want you to keep that moving forward from here because again, I'm thinking ataxia with anything alcohol involved. Call them ataxia. They have had too much to drink. So alcohol is a depressant. It's absorbed through the mucous membranes directly from the lungs, sweat, and urine. We excrete it, and it's metabolized in the liver. It can interfere with vitamin absorption, and then alcohol intoxication can mimic cerebellar diseases such as nystagmus, dysarthria, limb ataxia, and gait ataxias. We can have acute alcohol consumption. So that increases our GABA, which is inhibitory or excitatory? Inhibitory. So if we do too much of that, then your body's really agitated afterwards. That's why this withdrawal symptoms tend to be more tremor, agitation, tachycardia, all those kind of excitatory things. But acutely, we're thinking, hey, this person may have a really depressed symptom. Don't worry about memorizing blood alcohol concentrations or what symptoms look like. Chronic alcohol use, your CNS actually adapts to it. Think of your chronic alcoholic, you hand him a beer, does it affect him? No. You hand him 5 beers, does that affect him? No. You hand him 12 beers, does that affect him? Maybe. Once that alcohol tolerance really gets developed, those symptoms aren't going to show as easily. More often, you're going to see those alcohol withdrawal symptoms appear. So when we're dealing with acute alcohol intoxication, blood alcohol level doesn't reliably correlate because again, you can have those chronic alcoholics, functional alcoholics that have a sky-high blood alcohol content versus someone that doesn't drink that often may be more easily affected. Don't always rely on that blood alcohol content coming back to tell you clinical management. Treat them as they present. Management is typically supportive. There's no like magical reversal agent for alcohol. I'm protecting airways, I'm checking glucose, I'm checking for trauma. If I have someone that is intoxicated, can they reliably tell me that they weren't injured? No, you have to treat them, you have to protect C-spine, you have to pretend that, hey, this person may or may not have TBI in addition to. They can't reliably tell you they're not injured. And then monitoring for hypoglycemia, co-ingestion. What's co-ingestion? Something else. Think your gas station sober, because like, hey, this person drank a lot, oh, they're drunk. What else were they doing when they were in a state where they were drinking a lot of alcohol? There could be any number of drugs. Some of them might be reversible. I got to watch for cocaine. I got to watch for amphetamines. I got to watch for a whole bunch of other things that may be masked by having alcohol on board. And then watching for withdrawal symptoms. The typical onset of withdrawal symptoms, usually about 6 to 12 hours after my last drink, you can start developing tremor, anxiety, diaphoresis, nausea, tachycardia as the usual symptoms. And then once you get into that 12 to 48 hours, we see the full-on withdrawal seizures developing. And then alcohol hallucinations can start, and that'll eventually work into the full-on sequence of delirium tremens, which is kind of the combination of these, just once you hit kind of a really serious state. DTs isn't within the first 12 hours. It actually takes a significant amount of time for those clinical manifestations to develop. delirium tremens, severe withdrawal, delirium, autonomic instability, agitation, hallucinations, fever, hypertension. So I'm expecting abnormal vitals on these people and tachycardia. And the way we like to treat those is give them benzodiazepines. Yeah, we're suppressing things again, but we're spreading out that time frame where someone's acutely agitated. Can you die from the DTs? Absolutely. It's not let's sweat it out and kind of like see how things go and just put them in a corner and let them sweat out. No, we want to get them on something called CWA protocol. Has anyone ever heard of CWA protocol before? A couple of people? I'll describe it for everyone. So do not memorize. If you look up and you see a lot of stuff, yeah, don't freak out. It'll put you right at this level. So what the CWA protocol is it's a series of tests that we do. So they got the actual assessment here. And I look for nausea, vomiting, tremor, paroxysmal sweats, anxiety, agitation, tactile disturbances, auditory disturbances. It's all the typical symptoms, and it puts it on a 0 to 7 scale. Don't worry about like, I can identify exactly what that is. A lot of times the staff are very versed in doing it. When you actually pull out the full-on checklist, it tells you what to expect at each level. Depending upon what your score is, that's how much benzos that you're supposed to give them. And it gives you, hey, if I'm between a 5 to 9, I want to start at 1 mg. If I'm between 20 to 24, it's looking more serious, I'm going to start at 4 every 30 minutes. This is great because it keeps them very well controlled. You're not guessing. And I don't give them a one-time dose of benzos and say, all right, see you in a few, because it may take up to 96 hours for those full-on DT symptoms to develop. This one's based for lorazepam. Are you guys familiar with MME yet for morphine equivalents? Have you covered opioids? Remember how we convert like morphine into everything else and you convert it to morphine to get to something else? Just know that something very similar exists for benzos. Like if you have like, all right, my chart has lorazepam, but I want to give them diazepam instead. Cool, just go to the conversion chart. They have one for benzos and they have one for steroids too if you're trying to equate like, hey, methylprednisone versus predforte versus something else. Do not worry about memorizing anything on this slide. Know that CWA is a really good tool for you if you're dealing with someone with alcohol withdrawal. So outside of like acute alcohol intoxication, withdrawal symptoms, DTs, further on than that, I can actually have some vitamin deficiencies, and these are very common in alcoholics, so it kind of gets complex. I think B12 deficiency, especially due to poor intake, pernicious anemia. I think the sophomores have not had GI yet. The juniors have. You guys feel good with pernicious anemia. Sophomores, we're not going to test too heavy into the vitamin deficiencies because we haven't had it yet, so there's no fair question between the two of you guys. Just know that if I have a B12 deficiency, often IM or IV is the way to go. Has anyone ever heard of the term banana bag before, other than the fact that it's on the slide right here? So it's kind of this like weird yellow color because we're replacing B1, B12. A lot of B vitamins end up having a yellow color in there. Alcoholics will chronically get this over a long period of time to help their hangover cures. All we're doing is replacing vitamins that are lost in being alcoholic. You guys want to, what time do we need to break at? Are we there?
We can do another 15, sir.
You want to do another 15? Sorry, I don't know what time we started exactly. All right, appreciate you guys. All right, when we have acutely confused patients, nutritional difficulties, I can have Wernicke's encephalopathy. Is that related to Wernicke's aphasia? No, it's not. It's completely different. They're two different things. Wernicke was a really happening doctor. I think he was a German neurologist from what I could tell, but do not equate Wernicke's encephalopathy with Wernicke's aphasia, two very different things. So with Wernicke's encephalopathy, that's most commonly caused by a B1 deficiency. Make sure you memorize this for PANTS type questions. That's one of the things that you're like, oh, Wernicke's, B1 deficiency, got it. 2 points in the bag. Most commonly going to be in your chronic alcoholics. The B1 is the vitamin that actually makes a banana bag look yellow. I think B1, it just looks yellow. But making sure we're replacing this because it really reverses itself pretty quickly when you give them the vitamins. But it can also occur in malnutrition due to hyperemesis, people that are throwing up a lot, starvation, renal dialysis, cancer patients, critically ill patients, making sure we're checking these vitamins. Classically, the clinical triad of ophthalmoplegia, nystagmus, gait ataxia, and global confusion. What's ophthalmoplegia? Eyeballs, right? We're having some type of eyeballs aren't quite moving right, a lot of dysnagmus with them. Doesn't clearly fit like it's a cranial fork palsy. No, it's just kind of globally things aren't quite moving right with that dysnagmus, gait difficulties with the ataxia. Again, drunk people getting them into taxis, think ataxia, and that global confusion because we're dealing with an encephalopathy. And then Wernicke's is kind of the beginning of that. Eventually, it can get progressed to something called Korsakoff syndrome, and that's severe psych and neurodeficits. So I put this picture here to kind of show you how the two are related. Wernicke's is kind of the first half where you're starting to develop these symptoms, and then Korsakoff syndrome, again, really kind of long-term things. Does anyone know what the term confabulation is? Have we heard of that before in psych, or is that new and exciting? Where does it pop up at? Have you guys had that before, or is that a new word? I think that's a new word. We're going to discuss it. This is great. So you'll see this a lot in some elderly people sometimes where you say, hey, what happened to XYZ? And they'll tell you this crazy story, and it'll sound like they're like dead sure of it. And you're like, I think he's making things up. That's confabulation. What your brain is trying to do is like cover over the cues that are missing because it feels bad to have to like ask a very dark question, I'm going to make something up. They actually believe the things they're saying, even though they're kind of way far out there. It's not outright lying. It's their brain trying to cover up these gaps, and it may sound kind of ridiculous. So if you hear Grandpa telling you a real story, just say, hey, he's confabulating a little bit. It's okay. He doesn't mean anything by it. He's not trying to lie. It's his brain trying to cover up those spots that are actually missing. All right, Wernicke's encephalopathy into Korsakoff syndrome. The thing that we like to do is, if they're missing vitamin B1, give them vitamin B1. But make sure we give them B1 before we give them glucose, because you're going to be repleting. These guys have like, it might be an unhoused gentleman that you're dealing with in the ER, and they may be alcoholic and they may not have eaten for a couple of days. You're probably going to get them D5W and get them kind of repleted a little bit in your resuscitation. Make sure we get them thiamine before we actually start getting them on the glucose. The reason being, it can way worsen your symptoms if you give them glucose first, because that agitation is going to go through the roof. All right, we covered some of the selected cases of delirium. A lot of it kind of focused on alcohol and some of the effects of that from nutritional difficulties, which is great. Just know that any of the chronic illnesses, there's no really specific findings for like, hey, this person had cancer, therefore their neuropathy kind of looks like this. I don't have very specific slides beyond that. Just know a lot of those other causes can be there. These ones are very specific and they fit in neurology the best, so we went over those. Let's take a 10-minute break and then we'll jump into dementia. This is the best break spot I think we got. Break. I think he has you down for a Clin Skills 2 practice session. I think he's going to try to get some of the instructors downstairs. I'll wander downstairs too because I know you guys are just doing neuro exam and a bunch of other ones. But I think we were trying to do that at 2:30. So we'll shoot to have you guys down there by then because I think he's going to have some help if that works for you guys. And I'll spend some time with you after and walk through. If you guys got any questions, we'll help out. All right. We just finished talking about delirium. Those are those kind of reversible causes. Can be a bunch of different things that cause it. Alcohol is kind of our focus one because I got the vitamin deficiencies, I got the acute withdrawals, I got the DTs, I got the acute intoxication. All that can kind of fit within. It's a very common thing we're going to see clinically for delirium, especially in elderly folks. Now we're going to move on to dementia. We're going to start with mild cognitive and work through some of these ones. So dementia, I like this umbrella because it kind of gives the idea that dementia is an umbrella term. There's a whole bunch of different diagnoses that can fit under it. The first one that we're going to talk about, mild cognitive impairment. Dementia, it kind of like is like the step before dementia. It's the pre-diabetes of dementia. Dementia, frank dementia, it requires it to interfere with independent daily function. That's those ADLs, those activities of daily life. That's going to be someone that requires assistance. Mild cognitive impairment doesn't significantly cause that. So if I give you a case scenario and a test question, grandma's having a lot of confusion, but is still able to independently live on her own. Don't jump to all of these ones right away. If we're still having, hey, independently we can live fine and we're not having significant interference with ADLs. Does everyone in the room understand what the term ADL means? Those are activities of daily living. That's changing, that's brushing our teeth, that's changing our clothes, that's cooking food. Once those kind of fall out, I need a caregiver to help me out. Think of that for ADLs. And then we'll go through some of those ones more. I got a couple of just kind of dementia as a whole. Western society, Alzheimer's is about 50% of most of those, so it tends to be our most common one. And then vascular is kind of closely followed up. And then the different patterns, that just to kind of help me grossly recognize some of these things before we go into a ton of detail. Alzheimer's, think of the early episodic memory impairment. With vascular, it's going to be that stepwise decline in focal deficits. I put this lake here. Has anyone ever heard of lacunar infarcts? We'll talk about that a little more in the future, but lacunar means lake. So there's literally like small little lakes in our brain that aren't quite getting enough blood. It's not full-on stroke, but it's small little portions of our gray matter that aren't getting enough nutrition. And as a result, we start having these kind of stepwise declines of small little bits of information being missing. I can also have frontotemporal, so just think location in the brain. Do we remember Phineas Gage, the guy that got the spike through his brain? He had a lot of personality changes as a result, right? Like people did not like him. He was not the same person after that happened. So with those frontal temporal, I think Phineas Gage going through that one, I'm going to have early personality and behavioral changes as well as language, because that's where most of our language centers, Broca's and aphasias, are actually located. And then lastly, I've got dementia with Lewy bodies. I think Louis Armstrong playing the trumpet for grandma at 2 in the morning in her exam room. I have some type of visual hallucinations with Parkinson and fluctuating cognition. So anytime I see Lewy body, think hallucinations. The essentials of diagnosis, I have to have some type of progressive intellectual decline. Again, I don't want to take a delirious patient and label them as demented, because then I have a reversible cause that I miss. So I got to make sure it's progressive over time, not all of a sudden I become demented day one. And not due to delirium or other psychiatric illness. Dementia should not be diagnosed during the initial active delirium. Some people may be demented and delirious. You got to reverse all the causes and then say, hey, I still have cognitive baseline, not able to take care of my ADLs. I have baseline dementia with delirium on top. And then my main risk factor, please pay attention to this. I will ask a test question about this. Age is the main risk factor for dementia. Is smoking the main risk factor? No, it's going to be a really attractive option. Don't pick it. That's as blunt as I can be before Commander Ba comes in here. All right, so my different dementia types. I have mild cognitive impairment. That's the one that, hey, it still falls outside of those 1.5 standard deviations, but I'm still able to live independently on my own. I just like to think of it as like the prediabetes of dementia. Does that mean we can treat it? Potentially. I look for reversible causes. I look for things that kind of slow things down. There's no meds that are going to slow that down to prevention of Alzheimer's disease, but I can very early identify that they're going to need additional care. Sorry if I kind of misspoke a second ago. Still continue to treat these people symptomatically and give them the care they need. Just know, hey, this is going to progress over time. Increased risk of progression to dementia, but progression not inevitable. So sometimes they may stay in this mild cognitive impairment until the grave. That's okay too. All right. MCI often turns into frank dementia, frank meaning like true, not the person Frank. Usually it fits into Alzheimer's type, about 12% per year afterwards. Unclear why some people get worse and others don't. But again, number one risk factor, age. Memory deficit, outside of the norm. Pay attention to this. I'm not going to ask a crazy test question, but for whatever reason, the pants loves asking about these things. The presence of this apolioprotein, APOE is what it's just how to say it in typical English. But carrying one copy of this gene increases your risk of Alzheimer's by about 2 to 3 times, and having 2 copies of it like doubles it. We don't do a lot of genetic testing for this. It's not like some like colon cancers, but typically if you have like early onset dementia and a lot of family members, we start paying attention to it. There's a good chance APOE is involved in this. It's really just something that normally clears out toxic protein byproducts in the brain, and when those build up, we see the development of dementia symptoms. Small hippocampal volume and low CSF, yeah, sure, that's in there. Family history of dementia, kind of cluing you into they may have this kind of misfolded protein that causes issues over a long period of time, great. But again, what's my number one risk factor? Age, thank you guys. All right, Alzheimer's disease. Does anyone have a family member that's affected by this? I always love asking. I got one. I got a few actually. Okay, so cognitive changes is going to be one of those first things we see. The earliest classification begins with that episodic short-term memory impairment. Episodic meaning, all right, Repeat after me. Short-term working memory, that works great. But when I ask them to repeat it in 3 to 5 minutes, they're going to have difficulties. That doesn't necessarily mean long-term memory loss. They're still going to remember the things leading up to that point. But that may cause a lot of social difficulties because they don't remember interacting with people. They don't remember people's names. They have trouble kind of shifting. When one of those memory stages is broken, it's like 51st dates. Like, okay, I'm having issues putting that into long-term memory now. We have issues making new memories sometimes. Later findings can include language impairment, visuospatial dysfunctions. Has anyone ever seen, I wish I put a picture of it in there, but you ask a person with Alzheimer's or dementia to draw a clock, and all the numbers will be bunched up on one side and they'll be blank on the other. For whatever reason, the combination of putting numbers in a circle is like so complex for our simian brains that that's one of the first things that goes out of whack is that visuospatial, hey, draw a clock for me, all the numbers are bunched up, or the writing tends to be really small in these people as well. Look for those signs early. Executive dysfunction, again, that was like kind of all that kind of planning, preparing, the things that make you successful at IPAP, all those go out the window very fast. Apraxia, that's difficulty, even though I recognize an object, even though I know how to use it, and I verbalize I know what it is, I hand you a comb, I say comb your hair, and you're just not able to start doing it. Apraxia. And then behavioral symptoms. Genuinely speaking, memory impairment starts first, then we start seeing the language, visuospatial, super difficulty drawing clocks, and then executive dysfunction. So that's when we start to lose a lot of our ADLs, when we have difficulty just starting to do those things and planning the things out we need to do to take care of ourselves. And we can see early, middle, late, and end stage. All those are different ones. People in end stage dementia, end stage Alzheimer's disease, they can end up in something called memory care. Is anyone familiar with that or heard of it just kind of in plain English before? It's this idea that, hey, I'm to the point where I don't know where I am, or I may sundown, I may have waxing waning course. Those are the people that have to be in kind of an enclosed unit where people can reorient them to what's going on around them, to where they're not wandering off from an assisted care living facility. All right, risk factors, age, family history. Diabetes can increase our risk a little bit, and the major genetic risk factor, again, that ApoE, because we're misfolding proteins and they're just collecting over a long period of time, but age is your number one. And don't worry, even if you end up like genetic testing, it's not diagnostic. We don't have to go in and like take sections of your brain to determine, oh, he had Lewy bodies the whole time. That's usually found on postmortem. Early stages, memory loss, yes, I think we covered this. All right, so I know we talk about a lot of different A words that are neurodeficits that are kind of hard to define. I'm going to give you one more, I'm not going to test on it. Just know it exists for if you see it described. But asonoxosia, can't even do that. Basically, it's the idea that we are aware of our deficits, but we have a hard time actually acknowledging that they're aware. We have impaired awareness of our deficits. Patients may minimize symptoms while family members report functional decline. All right, middle stage, I couldn't even pronounce that. I really apologize, guys. All right, middle stages, patients may develop aphasia, apraxia, agnosia, with difficulty kind of naming things, visual spatial symptoms, behavioral symptoms, and then late stages, again, things are just kind of progressing. That's where we start seeing the sleep, wake, and the wandering start to happen, where memory care might be a really good option for these people. Delusions are very common in these people too. So we start seeing accusations of nursing staff happen sometimes. Take those serious when they do happen. Do the investigation. Elder abuse is a thing too. Just don't assume what an elderly person is telling you is delusions, but take it with a grain of salt. Do the trace down, make sure elder abuse is not happening. We see disinhibition. This can be unfortunate, especially for younger family members that are dealing with grandma or grandpa that is now disinhibited. It may come across as some very inappropriate behaviors or some inappropriate words that are said, and you're like, whoa, that's way out of character for them. It's just that they're disinhibited. They can't prevent themselves from doing those things anymore. And then we can see some kind of Parkinsonian type stuff with that shuffling gait, muscle rigidity, kind of very late phase. And then end stage, these people end up bedridden, mute, incontinent, rigid. Hyperactive DTRs and myoclonic jerks can happen. And death often happens from aspiration pneumonia, malnutrition, just because they're having difficulty eating, swallowing. Activities of daily life continue to break down where that can be a major cause of death. But aspiration pneumonia tends to be very common just because we get very ill from things in our lungs that should not be there. And then typical duration of symptomatic Alzheimer's disease is about 8 to 10 years. And just to understand the pathology, I think I wrote a test question about this one. I'll have to double check. If not, I will. This is very common for pants-like questions. People love asking about it. But in a normal neuron in our brain, things look normal. When we have Alzheimer's disease, we can have these things called neurofibrillary tangles, where the main portion of it starts to kind of look junky because things aren't getting rid of waste right. And then we can have these things called amyloid plaques. We've talked about amyloid plaques a couple of times before. Amyloid isn't the special substance. It's just a misfolded protein of one variety of another. Your body deals with a ton of byproducts if those gather up over a long period of time. Specifically, tau proteins is the one that happens there. There's nothing really special about that. It's just the byproduct that happens to be associated with nerves and Alzheimer's disease as a result. But just know that, hey, the neurofibrillary tangles and the hyperphosphorylated tau proteins, those are pathognomonic for Alzheimer's disease. A lot of times, pants love to describe those things because they think they're fancy words, and you're like, okay, I get what that is. All right, workup for these ones should evaluate for the reversible causes. Even if we're like, hey, I'm fairly certain this is Alzheimer's disease, I've got the family history, I've got everything else. Make sure it's not depression, which is known as pseudodementia in some cases. Look for the medications that may cause delirium in these people. Check the CBC, CMP, TSH, get that B12, especially if grandma, grandpa isn't quite eating right no more. And then neuroimaging, if it's indicated, focal neural deficit, something just kind of gets your hackles up. Don't be afraid to get an MRI. You may see some medial temporal and some hippocampal atrophy. Typically, we see the brain getting smaller and smaller as we age because things aren't quite feeding right anymore. That's one of the very hallmark findings I'm going to see in Alzheimer's disease for an MRI. How we actually treat these things, behavioral management, that's going to be like reorienting people to things that are around them, giving them cues, a lot of living things that you're not going to like prescribe for them, but just the actual treatments is trying to keep them oriented to what's going on around them and giving them quality of life in the meantime. Medication-wise, we consider some cholinesterase inhibitors. They can provide some modest symptomatic benefit. It's donepezil, rivastigmine, galantamine. They increase the amount of ACH, so we're getting like a little bit better transmission. It's like Paige trying to fix my microphone by turning the gain up over a long period of time because I'm talking less and less. You can only turn it up so many times though before he starts getting feedback on the microphone. Same things with these medications. I can increase your levels of ACH, but I may get some symptoms as a result from that. That was a good reference right there. I dragged you back in. I'm sorry if you're looking at another course. All right. You can. I did it when I was here too. Menantamine can be used for moderate to severe. It blocks us as some of the extra. I think I lost track of what I was trying to write for that one. Don't worry, I'm not going to test that one. That was broken. I taught it poorly. And then monitor cholinesterase inhibitor adverse effects. Typically when we give them too much ACH, so remember I got nicotinic and then I got muscarinic. Muscarinic, I'm gonna get that weird sludge type stuff. So nausea, diarrhea, bradycardia, syncope, weight loss, things that you don't want your grandpa to have. That's why we can't like, oh, just give them more and more ACH. We're gonna undo their Alzheimer's disease. There's a limited amount. Again, we're giving them kind of quality of life for those limited couple of years. That can be definitely worth it to people. All right, behavioral management, build rapport with these people, lots of memory aids, decrease the amount of stress they're going through because that can worsen some of the symptoms. I say baby-proof the house. I'm probably going to change that language to something less offensive. But the idea of like a home health survey, has anyone ever heard of that topic before? We all know what a PHA is, right? Or have done one. It's like a PHA, but for elderly folks, and you actually go to the house and say, hey, you're going to trip over this rug, or this, and this. PT can sometimes be involved with that too, but home health survey is really good for people. And then be aware of caregiver burnout, because this can happen very commonly for families. There's a lot of stress. Don't be afraid to say, hey, here's like this adult daycare thing. It sounds kind of ridiculous, but like just giving that family that's supporting this family member that may be disinhibited, maybe like a family member you loved a lot and still do, but are exhibiting a lot of weird emotional symptoms, that can have a toll on people over time. And make sure you engage them with support groups. Pretty much for any diagnosis, be it miscarriages, Alzheimer's disease, engage the family in like the local support groups and look those up. They don't have them in Alta, or Genesis, you can't order them, but just say, hey, my nurse that I know does this miscarriage group, go talk to her, because that can make a huge difference for your patients. All right, medications, just kind of read again. Don't worry about dosages, not going crazy into that. Typically, we can expect them to maintain like that similar like level of mental status exam for about a year, which is modest, but that can be worth it for people. And then this N-methyl deaspirate, I don't have too much experience in dosing this one, but again, this is for more of the severe. I'm not going to test too far into these questions. There's nothing too crazy for them here. All right, we got mild cognitive impairment. I got Alzheimer's disease, which is going to be that 50%. That's going to be my big ticket item for dementia patients. We're going to talk about a couple of the different ones, the vascular, frontotemporal, temporal, and Lewy bodies disease. So in that vascular cognitive impairment, vascular dementia, here, I like this picture because it kind of shows a lot of the different ways. This isn't one single person having vascular dementia. It's every single little different thing that we can have that affects our blood flow to our brain, and then as a result, we have kind of this slow, stepwise approach to dementia. Think of slow executive dysfunctioning, slowed process, gait disturbances, urinary symptoms. It could be a ton of different things. I look right here for these microbleeds, and they're just these small little islands, these small little lakes of bleeds, which are called lacunar infarcts, and it can cause some very strange symptoms in people. Think of people that have had a stroke recently, because those are your people that are going to have, well, it's obvious that they have some sort of vascular impairment of the brain, but there may be other smaller bleeds happening. Abrupt onset with stepwise deterioration. I think abrupt onset, I think, hey, something vascular's happened. Bleeds are the things that happen quick. And then focal findings with neuro exam, consistent with CVA, infarct seen on imaging. Whenever you MRI an old person's brain, just be ready for something scary every time you do it. You may see like a chronic like epidural bleed that's been there for a long time. You're like, oh my God, what do I need to do about that? And the radiologist is going to say, age indeterminate, unclear significance. You may see some very strange findings with bleeds that don't equate over to younger people. Just pay attention to older folks' MRIs for dementia. Be prepared for some odd findings. All right, frontotemporal dementia, that again is kind of localizing to that front side. I'm thinking kind of Phineas Gage in this one, where I have that very weird presentation of behavioral changes, personality changes. Typically occurs a little bit earlier than your Alzheimer's disease, so your 50 to 60-year-olds. Memory might be preserved. Again, we see memory and attention fall off with Alzheimer's first. With frontotemporal dementia, I think younger people with more behavioral issues afterwards. And there was, I don't think I go too far into this. I like this chart because it kind of broke down a couple of the different varieties. I can have that behavioral variant, frontotemporal dementia. I think Phineas Gage, I have a lot of those ones. And then I can have some primary progressive aphasias. So rather than just affecting my behavioral stuff, it's more the temporal. I can have semantic dementia, where that's like, hey, I've completely lost my ability to name things. That's like me trying to pronounce that word a second ago. I'm sorry, the syllables weren't just going to do me favors. I promise I'll pronounce it next time for you guys. And then I can have that progressive non-fluent aphasia. That could be apraxia, where I'm having like difficulty just getting the words out. But fronto, think a Phineas Gage behavioral health changes. Or I could see the temporal, where I'm having a lot of like word finding issues, even though my attention and my executive function is fine. Do not worry about differentiating out into this level. Just know, hey, I got frontal and I got temporal. I'll give you a combination of the two if I'm trying to clue you into this one. Don't try to memorize these individual categories. All right. Atrophy of the frontal lobe and temporal context on MRI. Again, I'm looking for small ones. Sometimes we can have tau protein be involved with that, which again is just a junk protein that's involved. I got a couple of these other ones that I've read about recently. I don't think there's any specific test questions. I don't think PANTS is going this far into it crazily. Don't worry about that. Do we typically get microscopic like biopsies of people's brains? No, that's why I was like, okay, gee whiz, and like the PANTS prep pros was like, oh, you got to test this. I'm like, we're not going to take a biopsy of someone's brain. A lot of this stuff ends up pathology. It ends up being found on someone's autopsy. That's why I'm not, you guys clinically, don't worry about things that you're not going to order. Frontotemporal dementia treatments. Again, watch out for that caregiver burden, because this might be someone that's younger, this might be someone that's still working, and this might be someone that has younger family members still that's having a ton of those behavioral health issues that can end up being very burdensome from the family. There's not really any disease-modifying agents, because again, the cause is a lot of smaller infarcts over a long period of time. We can't really reverse those. And treatment tends to be supportive. Caregiver education, safety planning, behavioral environmental strategies, symptomatic treatment. That might be SSRIs, SNRIs. That may be even up to antipsychotic medications. All right, dementia with Lewy bodies. What do I think of when I think Lewy bodies? Hallucinations. I think Louis Armstrong playing the trumpet. All right, core features, fluctuation of cognition, recurrent well-formed visual hallucinations. I got REM sleep disturbance behavior and spontaneous Parkinson's. So we can start to see this kind of Parkinsonian-like presentation, even though we might not have the full disease. Microscopically, again, yes, people clue into the fact that Lewy bodies is involved with this. We're not taking biopsies at people's brains to diagnose. This is going to be a clinical diagnosis over time with imaging. And then cognitive symptoms may occur before or within 1 year of Parkinsonian symptoms and disease. So usually within like 1 year of like I start to see Louis Armstrong, I'm going to start developing these Parkinsonian-like symptoms is very typical. And if Parkinson is treated with dopaminergic therapy, hallucinations and confusions may worsen. So watch out for this. Make sure when you're like treating someone for Parkinson's syndrome that they don't actually have underlying hallucinations. Because when I treat the Parkinson's disease, which may be their initial presenting thing, they've had hallucinations for a year before that, but they just didn't say anything. I'm not going to tell you if I see Louis Armstrong at the back of the wall. But what ends up happening is I treat them with dopaminergic therapy, I give them D2, and as a result, those hallucinations and that confusion may worsen a lot. So just pay attention to that when you're dealing with Parkinson's. Rule out the fact that, hey, is it Parkinson's or is it dementia with Lewy bodies disease? All right. Covered all of these ones. I'll give you guys a good comparison chart for these ones in the review slide for the next one, just to kind of like summarize it when we do our recap next time. I want to cover a couple of reversible dementias. I think I got less than 10 slides left. And I got 20 minutes until we're downstairs. So we'll finish up in the next 10 minutes here. All right, reversible dementias. I've got depression, hydrocephalus, and alcohol dependence. So with reversible dementia of about 1,000 patients in a memory clinic disorder, about 19% of them had some sort of reversible cause of dementia. 81% were irreversible causes. And the 25% between the two, they may have had reversible causes actually contributing to treatable conditions superimposed on. Basically, it's kind of a combination of the two is what this is saying. Not everything's clearly reversible or irreversible. The three most common causes that we can reverse is depression, that normal pressure hydrocephalus that we kind of introduced a while ago but didn't really know what to do with yet, and alcohol dependence. And then there's kind of a longer list of those, but stick to these three. That testable wise, I'm going to kind of clue into these ones. Don't worry about the whole long list here. Just know there's other ones that can contribute. All right, so pseudo-dementia, aka depression. I think just kind of treat it as that. We use the word pseudo because it's like, hey, we can treat it, this isn't true dementia. Depression is the most commonly mistaken for dementia. A lot of times people that are depressed can have impaired attention, which is the first thing that goes out when we think dementia and delirium. It may be processing speed. We may have like psychomotor retardation where things are kind of slowing down, decreased motivation, sleep, appetite, and memory retrieval. As we grow older, depression just happens and it doesn't present like a younger person that's going to say, I'm depressed. It's just Grandbeck becomes more and more withdrawal. All patients suspected to have dementia should be screened for depression and anxiety. So get them on that PHQ-9 and those GAD-7s that you guys know from psych. And then geriatric depression screening, there are some specific scales for elderly folks because that's harder to recognize than your younger population. Some of the differentiating things just clinically to raise your suspicion for depression. Dementia is typically unaware of the extent of their deficits. They don't know that they're having issues. A depressed patient knows what's going on. They know they're moving slower. They know they're forgetting things. They're aware of their actual issues. Dementia, not typically associated with a ton of memory loss. Depression, for some reason, is associated with memory loss. And then dementia, I have very few vegetative symptoms. These are people that are still kind of functioning and doing things like normal, we just have cognitive deficits. Depression, these people are going to be very withdrawn, the very vegetative state. They're not going to want to do things. They have very decreased level of energy. Dementia, very classically, worse at night, that sundowning syndrome. That doesn't happen with depression. Depressed people just want to go to sleep. And then dementia, abnormal neuro exam, possibly abnormal labs, depending upon what we're testing. But again, depression, a lot of that neuro exam, the imaging and the labs, that's all going to come back stone cold normal. Treatments, SSRIs, SNRIs, CBT, all the good things. Treat it like normal depression. And then anticipate a relatively rapid improvement in cognitive function. It's going to come back fast in these people. All All right, I've got normal pressure hydrocephalus. I think we introduced that last time when we were kind of talking structures about the ventricles. This one, I'm thinking that classic triad of wobbly, wet, and wacky. Again, no one ever presents with those to the ER. But when you're dealing with an elderly person that's presented by their family, and we're like, all right, I think we got some type of dementia delirium, I'm not really sure. He's kind of fallen over and he's urinating himself a lot. That's enough of a focal neural deficit for me to go get some imaging. Boom, I get the MRI, I see these huge ventricles. They're not supposed to be that big. You can tell because of the positive arrow sign. So when I start thinking that, I say, oh, this person has normal pressure hydrocephalus. That might be treatable, which is great. MRI ventriculomegaly out of proportion to cortical atrophy, meaning even though the brain might be decreasing in size as we grow older, it's the ventricles that are just huge compared to everything else. Management, we actually do what's called a large volume lumbar puncture, can decrease some of that pressure, and we can actually develop a shunt where it goes from the spine into the stomach or another location, and it allows that extra fluid to drain off over time. If someone responds really well to like doing a big lumbar puncture, I take off a lot of fluid and they cognitively get a lot better. That's a good indicator that the shunt's going to work really well for them. Some of the other reversible causes, we've spent a little bit of time with B1. Again, that kind of takes that, hey, I think this person has dementia, but then it fits more into the delirium category because it's reversible. I got classic presentation of confusion, gait disturbances, ophthalmoplegia. We kind of hit that on another slide. And then you can kind of put that in the Wernicke's and the Korsakoff syndrome where just think alcohol withdrawal, vitaminosis being, vitamins aren't quite working right, sorry, not osis, but vitamin deficiency is either B1 or B12. And then think, all right, am I dealing with a Wernicke's? And I'll make sure we have a differentiation slide so you guys can like see an alcoholic and know what's different to put it on that category. I know there's a lot of crossover between some of those diagnoses for now. Korsakoff syndrome, think of that anterior grade amnesia, thinking further and further back we go, the harder it is for us to recall things. And then again, if we're replacing B1 in people, check the glucose first, or before glucose, sorry. Make sure we replace the B1 before we give them glucose. All right, B12 deficiency, cognitive changes, neuropathy, posterior column dementia, gait instabilities, macrocytic anemia. I'm not going to ask too many crazy questions on B1 or B12 because I know it's kind of mixed as far as what the sophomores have and what the juniors have on this so far. And then making sure we're watching for medications. Our highest risk ones, anticholinergics, the benzodiazepines, opioids, making sure we don't have a bunch of medical patches going across our stomach because we're in palliative care. The sedative hypnotics, muscle relaxants, antihistamine drugs, antipsychotics, and then polypharmacy, just the total amount. But as you move on into clinical practice, especially the people like going into the civilian sector and you're seeing elderly folks, pay attention to the Beers list, especially where does geriatrics actually start? What age? 65 in most people's like jurisdictions. As an active duty PA, can I see over 65? Depends. So I didn't realize this until I actually looked at what my credentialing said, and it said, hey, between 2 and 65. And I was like, I'm seeing 66, 67-year-old like ATC dudes. Like I gotta pay attention to what I'm, when you actually get credentialed, pay attention to what your packet actually authorizes you to do. Because sometimes they'll limit it and say, hey, over the age of 65, you can give them medications that makes things much worse. You might not be aware of Beers criteria. And a lot of times as you become geriatric, they'll shuffle you over to internal medicine, which is allowed to see up until 99. And then to see past 99, it's like super high risk. They may die in the waiting room. That ends up being its own separate risk level. But just pay attention to what you're authorized to see. All right, general symptoms treatment, identify reversible causes and treat it. Remove the sedating medications and treat depression aggressively. And the behavioral problems, take care of those environmental cues for reorienting, getting them exercised, and memory aids. For delirium, use reorientation, sleep-wake normalization, mobilization, hydration, glasses, and hearing aids. We see this a lot in elderly folks where multi-sense issues can cause a lot of problems. Even though they're normal, they can't hear, they can't see, they have a hard time interacting, and that can cause cognitive decline over time. So making sure we're fixing vision issues, we're fixing hearing issues is really important for our elderly folks. This is turning into a geriatrics class, I apologize. That's a separate one for peds. And then antipsychotics may be used for severe agitation and threatening safety, but do not treat the underlying cause of delirium. And avoid antipsychotics, especially with those Lewy body dementias. This is going to cause a lot of issues if we add that on to Louis Armstrong. think this is just kind of a recap of our normal delirium versus dementia comparison. That's going to be a dichotomy. And again, I'll create some comparison slides so you guys can pick out the high topic things. I know a lot of these conditions kind of have a lot of overlap between them, but I'll highlight them in our review next time so you guys can pick out and say, hey, how do I differentiate? And I'll give you some questions that show you how I like to differentiate them. All right. Key points, unexplained AMS workup should be guided by the clinical context, but always consider glucose is very important. Hypoglycemic, it's one of the fastest, easiest ways to treat it and say, oh, I don't have to do this whole big workup. Probably still have to, but it's one of the first easily treatable ones you need to consider. Oxygenation, COPD patients can end up hypoxic very easily. We watch for infection, metabolic derangement, intoxication, withdrawal. Again, alcohol was a big portion of this, especially in our elderly folks, our chronic alcoholics. Symptoms may mask very easily. Trauma, elderly folks, they fall down a lot, and when they hit their heads, they don't always tell you they hit their heads. We watch for seizure and strokes. This should be our baseline workup. Do we want to do an LP every single time, a blood culture, imaging? No, it depends on the clinical scenario. Is getting an LP done kind of fun? Not really, it's kind of tough, especially on someone's grandma. Just pay attention to your clinical signs. It's like, hey, I have a clinical index of suspicion. This is what I want to add on. If I get a brain MRI in an elderly person, is that going to be scary sometimes? I don't know what I'm going to find. So base it upon the clinical scenario. I can't tell you, hey, here's what you want to order every single time you got altered mental status. There's no like one size fits all. Based upon your clinical index of suspicion, start with the glucose. All right, management of delirium is treating the underlying medical issues. And the hallmark of delirium, this is probably going to be testable, waxing and waning mental status when it kind of comes and goes. That's not what dementia actually presents like. Quick review. We covered Alzheimer's disease. We covered that vascular dementia. We covered frontal temporal. That's going to be Phineas Gage with those behavioral difficulties. And the temporal, some of the language difficulties. Lewy body, I think Louis Armstrong. I think some type of hallucination. He's in the corner playing the trumpet for me right now. Normal pressure hydrocephalus, that was that weird, wacky, and wobbly. Again, I'm going to get that because I get imaging, because I'm like, hey, this guy really isn't presenting right. He has neurodeficits. I get a brain MRI and I see huge ventricles. Normal pressure hydrocephalus, get some of that extra fluid off. And then lastly, check the medications, check for depression, and thyroid and alcohol. Those are going to be your high ticket items. Again, I'll create some comparison charts for you guys that allow you to differentiate a couple of those. Sophomores, I think some of the instructors are getting ready for you in the next 10 minutes down below, and I'll be available for like the next 5 minutes for questions. Thanks, guys.